Hello and welcome to Workers' Comp in Motion, our Boottacular webinar. We'd like to thank our sponsors today for putting on this program and getting such an excellent group of experts together for you. Our sponsors include the Institute of Health, NewQuest, ProLogic, Work Partners, MacroPro, Siegel, Marino and Stetler, ProCare, GenX, Corvell, iRatings, Learning Services, Ember Court Reporting, Optimum Dental Work, and California Orthopedics. We'd like to thank you all for participating in today's program. Today's presentation is worth 1.5 CEU credits. You will be receiving an email within the next 24 hours. In the email, there'll be a little blue box that says My Certificate. Please download that and keep them for your records. If you'd like a copy of today's handouts, they are available to you via the control console. And if you'd like to ask our experts any questions, you can do so using the question box. And our experts will be reading those questions and answering them at the end of their presentation. And then lastly, we will be doing door prizes today. So hang around to the end to see whether or not you are a winner. We have a great panel of speakers, and our topic today is systematically reversing the overall cost of claims in the age of COVID. And Mark Pugh is our moderator. Doing today, how are you?
Hey, Diane, great. How about you?
I'm okay. So how are things in Atlanta?
Well, going very COVIDly, working on my Lord of the Rings look here. It feels like San Diego in Atlanta, so very, very comfortable. So, and we've got a couple of folks from San Diego, so we'll be able to compare weather, I think.
Well, great. So who do you have on your panel today?
We have got some great gentlemen that are very smart on this particular subject, but I'm going to let them introduce themselves. Just in case anybody doesn't know, I'm Mark Pugh, so I'm the one with all the hair. And I won't make any statements about Ken, but Ken, we'll go ahead and turn it over to you and let you introduce yourself.
Thanks, Mark. I could probably use some of that hair on your beard to put on my head. Good afternoon, everybody. Ken Hernandez. I am the long title. It's the Chief Risk Safety and Asset Manager Officer for LA Metro. I'm basically the Chief Risk Officer, Chief Safety Officer, however you want to say it, but it's an awful long title. Anyway, a little bit of a bio on me. I've been about 28 years in the industry, risk management industry, doing claims, safety, and insurance. I started out, I've done both public and private sectors. I started out in retail in the grocery industry with, I'm going to date myself, Alpha Beta, Lucky's, Albertsons, and then I went into Sears and did claims and safety with Sears. Then I transitioned into the city. So I was a risk manager of City of San Bernardino, Orange County Sanitation District, and I was also, some of you might remember me, I was the Director of Risk Management for San Bernardino County back when we had the mass shooting in December 2nd of 2015. So now I am with LA Metro, and I cover, I oversee all of claims, work comp, property, liability claims. We're self-insured, self-administered on the work comp side. We have a TPA on the PDPL side, liability side. In Carl Warren, I oversee safety, and we have a huge safety department, as well as all the assets, asset management within LA Metro. I just want to say I'm excited to be here. I think it's a good topic. I'm excited to discuss and work with such a distinguished panel. So thank you for inviting me, and I'll turn it back to you, Mark.
Thanks, Ken. And before we let you go, I would like to ask you one thing that you've either gained or lost during COVID that you'd like to share with people. There may be some stuff that you've gained or lost that you don't necessarily want to share publicly, but anything that you've either gained or lost that you would like to share with us in regards to this crazy 2020 we've been in.
Well, I can say that I've lost hair, but I think I already lost my hair previous too. I gained a lot of experience. Let's put it that way. There's a lot going on, and I think it's important that we learn as we go, and we're facing a lot of issues that we've never dealt with. So I think experience is one, and every time that we do something, we try and gain a little experience and then pass it on to those others who maybe not have been fortunate enough to learn. So I think that's important.
Gotcha. Great. Well, thank you, Ken. Next is Dr. Randall Browning from Work Partners. And I love for Dr. Browning, I can't do justice to his CV, so if you'll introduce yourself as well.
Okay, thanks, Mark. Yeah, Randall Browning. I'm the Chief Medical Officer for Work Partners Occupational Health Specialists. That's a network of clinics in San Diego County. I've got about 30 years of experience in the op med arena. I also specialize in emergency medicine and toxicology, poisonings, overdoses, things like that, particularly occupational and environmental toxicology. That's me.
Wow, that was quick. So can you give us something that you want to publicly disclose that you've either gained or lost during COVID in this crazy year?
Yeah, this has been a real experience for all of us in the medical field because we're having to navigate all this new knowledge that wasn't here a year ago. And it's been I've gained some great experiences doing that. What I've lost is I've lost the commute between all the clinics, so I get to save a lot of time.
And you are a Zoom aficionado at this point. I think we covered that the last time we got together.
That's right. That's right. Okay.
Absolutely. Well, thank you, Dr. Browning. And last but not least, Dr. Tomer Anbar, who's with the Institutes of Health. Dr. Anbar, if you'd be willing to share some background on what you're doing, and I'll ask the same question at the end as well.
Thank you, Mark, and thank you for putting together such an extraordinary conference. So my name's Tomer Anbar. I'm the clinical director and original founder of the Institutes of Health. I'm founder and first director of the Chronic Pain Rehabilitation Program at Scripps Health in San Diego. And then formally, I was at the National Institute of Neurology and Neurosurgery, part of the research unit of the World Health Organization in Mexico City. And over the past 15 years, I've chaired the division of pain rehabilitation of the American Pain Society and of the International Association for the Study of Pain, which is comprised of about 133 countries. The Institute, among our various areas of work, we specialize in reversing 4 of the principal epidemics that impact work comp, both in terms of disability and costs. And that is chronic pain, brain injuries, PTSD, and sleep. And I'll be able to go into that. And then, Mark, the question about what has impacted me or how I feel impacted in the world of COVID. I think personally and professionally, it's been the experience of being immersed in overwhelming uncertainty in all aspects of our life. So that's been tough all around. By the way, we did a musical tribute to first responders and colleagues that I invite you to see on our website. It's pretty cool, and that's at institutesofhealth.org. And then I'd say the silver lining has been that we've been working probably for 15 years on developing an online platform that would permit us to treat people in remote areas with all these conditions. And it was actually thanks to COVID that really pushed the healthcare industry online. And so we were very fortunate in being able to actually flip a switch and move all of our clinics online. As I can mention today, we're able to do everything from checking people's lungs to looking in their ears and throat online, but particularly our ability to treat. That's not just us, but that's many treaters, you know, across the country and around the world. So that's, I'd say, a huge silver lining.
Gotcha. Well, thank you, Dr. Anbar, and I would second that because I think in my perspective, what I have lost is the sense of status quo. We have assumed that every day is going to be like the day before, that I was going to be on Delta and flying to California or flying to New York or flying to Dallas or that I would be having in-person meetings, that I would not be sequestered with my wife for 7 days a week. There's a lot of stuff that I had just kind of assumed was always going to be there, and COVID has definitely yanked the carpet out from underneath my feet and everybody's feet, really, on this particular webinars, including the attendees. Hopefully those of you who are attending see just the breadth and depth of these three gentlemen and their personal perspectives on things. And you can see we got different perspectives as well. And we're going to really leverage that as we go through it. But we're going to start with Ken, and he's going to guide us and talk us through a little bit what he has been undergoing on the front lines as an employer, as a risk manager, associated with COVID and the impact on public transit. So Ken?
Thank you, Mark. I just wanted to start off to say, that COVID hit us, and as the numbers increased throughout the country, many Americans are experiencing this from afar. A lot of you are watching you're working from home, you're watching things on the news, watching things on social media and Twitter, and when it hits an employee or it hits a family member, and they get hit with the virus, it changes things drastically. And for those of us that are still healthy, watching the outbreaks on graphs and Twitter, I just think it's important to keep it in context that this is a serious matter, even though we're doing what we can to get through it. And I just wanted to start off with that and how serious this pandemic has hit. A little bit about my agency and some of the things that we've been doing. We're on the front lines. We provide mass transit throughout LA County. Essential transit for essential workers. We provide both train and bus, rail and bus, and bikes throughout LA County. And our employees are here 24/7. So I think I've taken a couple days off since March, but for the most part, we're here at the office, 10, 12-hour days, putting in time to make sure that we provide this essential transportation. We have about 11,100 employees. 8,000 of those are operators of our trains and buses. So the predominant amount of our employees are on the front lines dealing with the public. Our ridership dropped tremendously, as you can imagine. And when the beginning of this pandemic, we were about 1.2 million riders a day. It dropped to about 100, 125,000 when everything was closed due to the pandemic. And it's been increasing pretty good as well. By the time we put this PowerPoint together, we were about 600,000, and it's been about a week and a half, 2 weeks since then. We're up to 625,000. So we're over half of where we need to be. The new norm is going to be different. We're not exactly sure where those numbers will fall. But as you can see, we still provide a lot of service day in, day out for LA County, and we also touch the 5 adjacent counties. So we've tried to incorporate as many safety protocols in place to ensure a safe workplace for our operators. To give you some of the examples, some of the stuff that we deal with and our operators have to deal with. Our buses, we've implemented a rear door only entry, so which means our front doors don't open. So the patrons come through the back door, even though they usually pay to the front. We're not saying that transit is free, but we're not policing it and we're not enforcing fares at this time. So the revenue drops even more because we're not enforcing fares, but that keeps everybody in the back, towards the back, away from our operators. And also, operators are wearing the PPE, the masks, gloves necessary. We also provided barriers. Now, what they have is a plexiglass barrier that separates them from the patrons. And we've done this a couple of years ago, but it wasn't mandatory, and a lot of the operators weren't using it. When COVID hit, we made it mandatory, and the operators loved it now because it separates them from everybody else. So it gives them a little bit of a barrier. It is removable, and it opens and closes. So they have to open it when they still have to load passengers coming on the buses. So for ADA compliance, they'll still have to go load a wheelchair. So for that, they still wear the mask, and we've given them the extra face shields to protect their eyes from the patrons. But our riders face a lot. Our patrons face other obstacles, such as one of the most common work comp claims we have in the bus operators, and you'll probably be surprised to hear, is our operators get spat on a lot. For some reason, people like to spit in their face, and that's on a regular basis. So could you imagine COVID, the fear of coming to work and getting spat on? It's not anything that you and I think about on a daily basis, but that happens to our operators. So those are some of the things that we're facing. We also had the windows going up and down as far as circulation, air conditioning system. We've also dabbled in testing for UV for as far as cleaning the buses. So those are some of the protocols we have in place. Masks is a huge issue. We mandate masks, as you know, they mandate masks anywhere outside. They mandate masks on transit. However, it's not enforced. And one of the reasons why we don't enforce it is because it's hard to police. We contract, we have security of our own. We contract with LAPD, LA County Sheriff, as well as Long Beach and some of the local agencies, but they can't be everywhere. We have too much transit for them to be on all of our transportation. So we're not going to put our operators in that situation where they're policing it. However, I will tell you that we've done surveys, and anywhere from 97 to 100% of patrons are wearing masks. People are just getting used to wearing masks on a daily basis, but we typically can't enforce it. And that's where we have issues from some of our operators, so the fear of that, and also from the media that's saying that we're not doing what we can do in enhance and support a safe workplace. As far as COVID claims, well, real quick, let me just run down some numbers so you get an idea of how much claims we're dealing with in-house. Of the 11,100 employees, we've had a total of 404 cases, positive cases. 142 of those are contracts, 262 are employees. So when you talk about 262 positive cases out of our 11,000, you're looking at roughly like 2.3%, which is pretty low considering most of our people are out on the front line. So that's good. And we've also had 238 recoveries. So we're looking at about 24 active cases at this time. But our work comp claims, we've only had about 20 claims, which is fairly low, I know, considering our numbers. 11 of those are psych. And a lot of what we're seeing is that people are afraid. People are afraid to come to work. They're afraid of getting spat on if you're an operator, having an altercation with one of your riders. We don't enforce a lot of that, so it makes it difficult. But even the return to work, the 3,000 that are administrative and support staff, a lot of them are telecommuting. We try and push out as many people as we can. However, now that we've done that since March, a lot of them are afraid to come back. And although the things are leveling off and we're not seeing the high numbers that we have in the past, it's going to be hard to get some of these people to return to work. We've put a lot of protocols in place is for physical distancing, social distancing. But the fact that the people are starting to realize that maybe I can get a lot of this work done at home, the fear of coming back has been an issue. So we've tried to put return to work programs together, trying to get these people back. And we're going to continue to work on that. We're not planning on bringing everybody back till after the first of the year. As you know, LA County is still in the purple stages. So as they go down to red and then orange, we'll look at bringing people back. But how the LA County numbers fall is an indication of how we are bringing our employees back to work. So right now, we still have a good portion that are out of the administration and support staff. So those are some of the issues that we're dealing with, some of the protocols we put into place. A lot of the things that we're doing, we deal with public health. LA County Department of Public Health, we deal with them almost daily. And you would think that since they're part of LA County, that we would be following a lot of their protocol, but we try and follow as much as we can. And let me give you an example. What they provide is guidelines and recommendations. Because we're mass transit, a lot of the stuff that they could do is not practical for us. For instance, like mask wearing. Even the FDA came out and said that we're not enforcing mask wearing on mass transit or on in a lot of the airports. I mean, on a lot of the airlines. Same thing with physical distancing. We can do it to the extent practical, but when you're talking 600,000 riders a day, when you're talking getting up to possibly 1 million riders a day, it's not practical in all our divisions throughout LA County to enforce the mask issue. And let me give you another example. We've had, when we talk about surges, for those of you that are employers, and anytime you have a surge, LA County tells us if you have a surge 3 or more in one location, you have to report that surge to LA County. So once we report it, they'll come out and they'll look and just make sure that we're following the protocol and make sure that we're following it. The guidelines. Well, the guidelines for us are a little different than if you go into a restaurant or, based because they're strictly enforced by those guidelines, and we're not because we're mass transit. So they came out and did an inspection of one of our work sites because we had a surge. And they cited us. Well, they didn't cite us, but they had a lot of alleged violations. So as you can imagine, I was questioning them because what regulation are we violating? What code? What law? what health order are we violating? And when I got the upgraded, I spoke to county council, went through it. I got the uploaded new health orders, and determined that we're exempt from all of them. And my explanation was, we're doing everything we can. We're looking at your guidelines. We're trying to physical distance where possible. We're providing the PPEs. We're providing protections, hand sanitizers, place to wash your hands. We're doing what we can, and we approve, and we appreciate it. But some of the things they want us to do is test our employees before they enter the workplace. It's not practical for us. And we have our employees self-monitor. We're not doing temperature checks, and we're not mandating employees to get tested. So those are the violations that they said that we had. After the discussion with them, looking at their health order, we had a follow-up meeting where they agreed with us. So the health order has been a big part. I mean, the health department has been a big part, the CDC, World Health Organization, of what we do and how we put our protocols in place. But we don't follow every one of the guidelines. We do what we can. But the goal is, we still have to provide a service for essential workers. We provide transit for police. We provide transit for fire. A lot of the health workers in the industry, they use our means of transportation to get to where they go. And so we provide as much of the protocol in place as we need to, but there are situations where we have to have a discussion with the health department on things that we can and can't do. We have an excellent relationship with them, and we appreciate the input, and we try and do what we can to abide by as much as we can to provide the safe workplace. So those are some of the issues we deal with. We have had a couple employees that that passed away due to COVID. We had 2 operators and 1 contract. So it brings back the seriousness of the issue, and the fact that we need to do everything we can to maintain a safe workplace. And we will do so as well on the return to work, and ensure that when everything starts to open up, that we're ready to accept everybody, and that we're ready to provide a safe workplace for everybody. But I will tell you that things are changing. It's a public sector, and even though we're not used to telecommuting, going forward, we're putting a telecommuting policy together where some employees will be doing that full time because of COVID, and because they've proven that they can do it. And so it's going to be interesting for us as management and leaders to be able to lead through that, something that we're not used to. So we're working through it, and we'll continue to work through it. So I just wanted to say that I'll be available for questions if you have any, and I know we'll do some follow-up after that. And so again, thank you for letting me speak to you, and I'll turn it back over to you, Mark.
Great, thanks, Ken. Appreciate that. You've got a lot going on, to say the least. I do have one question. I did notice yesterday, actually Monday, that the CDC came out with some new interim guidelines in regards to public transportation specifically, and they strongly recommend masks for both patrons as well as the employees. But I noticed an interesting quote in there. It says, well-fitted face coverings. So, everybody's got something that they're putting on. Some of them look like bandits from the 1860s. Others got the N95 with the full thing. I know medical practitioners, and Dr. Browning can probably speak to this at some point. There's training for actual doctors and clinicians on how to put the mask on. So when you're walking through with your employees in regards to wearing their mask, how do you approach that? Do you train them on how to do masks? Do you give them masks? Do you give them guidance on that? Is it gaiters versus the surgical mask? How do you handle all that?
Well, that's a good question, Mark, and it's actually a blend. If we provide the N95s, then based on OSHA guidelines, we have to train them, and we have to give them the protocol on how to wear them, how to don and doff your mask, how to wear them properly. We do have N95s in stock. We don't give them to all our employees. We give them to those employees that need it for the course of their employment, and we also give it to some of our operators that are recommending, that are requesting those because of the nature, and they're on the front lines. So we give it to some of our front lines. But N95s are not something we give to everybody because of the fact that you have to wear them properly, and you have to be trained to do so. We have them in stock in case they request them. All of the other masks, as far as face coverings, we did issue several black masks that had a Metro logo, and we issued 4, 2 black and 2 white to every employee in the industry. And then you're basically your cloth masks. And there are people that wear the gaiters, And there are people that wear different types of masks. All we're saying is they need to wear a proper face covering that covers your mouth and your nose. And it's basically to prevent particles from getting out. It's to protect other people from you. And so we have a blend. We have about 5 different types of masks that we issue in the workplace. So it's a blended.
Got you. Great. Well, thank you so much, Ken, for that great insight. We're going to switch to a different perspective on the front lines with Dr. Browning in his occupational health outreach. And he is actually, and his clinics at Work Partners have actually been treating a bunch of COVID patients, certainly from a work comp and occupational health standpoint. So Dr. Browning, I will leave it with you.
Okay, thank you, Mark. So in our clinics, we only do occupational medicine. We don't see the general public. We're not in urgent care. We just do work-related illness and injuries. And in our clinics, we see about 500 to 600 COVID evaluations per month. That includes both testing and telemedicine and in the clinic. Of those, about 13% come out positive. Now, that's a pretty high number for a positivity rate. And I think the reason for that, because a lot of communities around here are 3%, 6%, something like that. 13% is pretty high, but I think the reason is that there's a selection bias. We get sent patients that are suspected of having COVID because of their symptoms or have had a close interaction with somebody with COVID. All of these are employer referred, so these are all patients referred to our clinic by the employer. The people that do get COVID, I'm gonna change what's on the slide here because that's not exactly right. The people that do get COVID, in our experience, have about a 60 to 70% rate of getting better, completely better, within 2 to 3 weeks. Okay, and those are for outpatients. We're not talking about inpatients. Now, who do we see? Well, we see lots of different groups. We see first responders, of course, police and fire. The interesting thing about first responders is that their positivity rate is lower than the general population, which might be surprising. A recent study in Arizona of first responders showed their positivity rate to be 1%. And what that shows is that they're using their PPE and their PPE is effective. So that's kind of a lesson for all of us, I think. Of course, we are seeing healthcare workers because they're on the front lines. This next group is kind of interesting. It's caregivers and teachers for special needs children. And why do I choose that? Well, some of these children can't tolerate a mask. And some of these children are in a high risk or vulnerable population. So if they can't wear a mask, that will put the teacher or caregiver at an increased risk. So we have to be very, very careful about that. And then workers in large groups. Imagine a agriculture company that brings in 300, 400, 500 guest workers during the season and houses them in a dormitory type situation. Well, that's a bad situation. If somebody gets sick, then it can spread like wildfire. So we work very closely with our agriculture folks and anywhere where people are working in groups. And then there are the workers that are testing positive or getting worked up for exposure outside of the workplace. And then the question is, when is it safe for them to come back? It's the return to work question. So if I said that 60 to 70% of people in the outpatient setting with COVID-19 get better within 2 to 3 weeks, then that leaves 30 to 40% of people with COVID that don't get better within that time period. There may be complaints of severe fatigue. There may be complaints of lung issues like difficulty breathing or cough. There can even be some heart issues like inflammation of the heart or inflammation of the lining around the heart. And then a lot of people complain of persistent difficulty concentrating or not able to think as clearly as they did. So what are the rates of this? Because this is what's really of concern to us and to employers that we work with is, it's one thing to have an employee that gets COVID-19, is sick for a couple of weeks and then gets better and is able to go back to work. It's another thing altogether to have an employee that gets COVID, gets over their acute illness, and then has persistent symptoms preventing them from coming back to work for weeks or months or longer. And that's what's concerning about this situation. So who is it that's at risk for having these long-term problems? Well, their age is a factor. So amongst people 18 to 34 years old, roughly a quarter of them, after they recover from their acute illness, roughly a quarter of them will have persistent symptoms, fatigue, cough, headache, shortness of breath, that kind of thing. On the other end, those that are over 50 that have COVID and get over the acute injury, about half of them will have these prolonged symptoms. But I have a caveat here, and that is that some young, healthy, active people that get COVID and maybe have very mild disease, they can have these chronic issues as well. I had a police officer that the thinking is he contracted COVID during an altercation and arrest of a COVID positive person. And although he got over his illness fairly quickly, he got to the point where he was no longer shedding virus and he was no longer contagious to other people, he had persistent symptoms that prevented him from going back to work for a couple of months. Persistent severe fatigue, shortness of breath, that kind of thing. So these can be some serious issues. Contrast that to the flu, influenza. With the flu, 90% of people are completely better within 2 weeks. So this is a different animal. COVID-19 is a different animal from the flu, and part of it is because of those chronic symptoms. Now, I have been talking about outpatient, the ones that we see in the clinic and can treat completely in the clinic. What about the 20% of patients that get COVID and are sick enough that they have to go to the hospital? Because 80% are mild enough they can stay out of the hospital. 20% end up going into the hospital, and 5% end up on a ventilator in the ICU. What about those people that have more severe illness? Well, they have long-term symptoms too, but it's a higher percentage and it's a longer period of time. So nearly 90% of people that were hospitalized for COVID-19 have persistent symptoms after their acute illness is over, after they're no longer contagious, after they're no longer shedding the virus. And so the question is, how long is this going to last? How long do these, we know it's at least weeks or months. Could it be years? We just don't know yet because it hasn't been around long enough. What we could do is go back and look at other coronavirus illnesses that we know about. And one that comes to mind was a coronavirus pandemic in 2003, SARS. Severe acute respiratory syndrome. Now, that was a different coronavirus from the one we're dealing with now, but it is a coronavirus nonetheless, and so it makes you wonder if there are some similarities. And with the SARS epidemic, people that got SARS, 40% of them still complained of fatigue even after 3 years. So we don't know how long this is going to last. So we talked about milder cases that can have these long-term sequelae. We talked about more severe cases that can have long-term sequelae. And there's one other issue that I want to bring up, and that is the psychological part of it. We are now getting good data from around the world, from China, from Italy, from Spain. We're getting good data that frontline healthcare workers, even if they don't get COVID themselves, they have a measurably increased frequency of depression, anxiety, and insomnia. And so these are the things that we're dealing with now, not only the acute illness, but the lengthy symptoms that last after that and the psychological manifestations. And that is our state of play on the OC Health front. Mark?
Thanks, Dr. Browning. I've got a follow-up question for you, since we're dealing in a work comp industry, and chances are really good that our audience is filled with claims adjusters, nurse case managers. going to be handling these claims. You've talked about fatigue, you talked about pulmonary issue, the difficulty concentrating, reduced cognition, neurological issues. You talked about depression, anxiety, sleep deprivation. Those things typically aren't work comp related things that we're dealing with from a chronic standpoint. Of course, we're not used to paying for diseases either. We're used to paying for injuries. So this has opened up Pandora's box. One thing I didn't see on there was pain, which, chronic pain, which obviously can come from a variety of different sources, is one of the main cost drivers for work comp. Do you see, or do you have any insights into how pain may be a part of this lingering, persistent, I think you mentioned 40% and SARS had fatigue of 3 years later. So we're looking at something that potentially we might not be able to close the claim immediately like we think we can, because there's going to be persistent symptoms if it was work related. So what do you think about pain, and what do you see coming in that regard?
Yeah, most of the pain in this illness comes during the acute illness. But in terms of the lingering symptoms, by far the most common one is severe fatigue. Pain is one, muscle pain, myalgic muscle pain, but that's really only about 5% of people that have persistent pain. So pain is not the biggest problem. The biggest problem is shortness of breath and fatigue.
Okay. So with that being the case, we're going to be learning stuff from a work comp standpoint on how to mitigate, how to establish risk associated with that, actuarial tables on how you figure out premiums and, all that kind of stuff. We're branching off into a whole new land that we've never been in.
Absolutely, yeah.
Scary. Well, thanks so much for Debbie Downer for letting us get up to speed on that. But it's really important, I think, for people to understand. You can read a lot of stuff on Facebook. Please don't, but you can read a lot of stuff on Facebook and you won't want to leave your house. So it's really important to get real live data and statistics from the front line. So Dr. Browning, thank you so much. With that, we'll move on to Dr. Anbar, who is really focused on rehab. And has historically, as he mentioned, focused on TBI, PTSD, chronic pain from a rehab standpoint. That Pandora's box that we're opening, Dr. Anbar, you're going to have to try to figure out how to deal with all those things that are coming out of it. So if you can guide us through kind of your rehab front lines, we'd appreciate it.
Thank you, Mark. I think you brought up some fascinating points. And I just want to mention that how extraordinary it is to see how the Transit Authority, how Ken's organization is managing this whole pandemic, and their outcomes are really quite extraordinary when we're thinking about 11,000 employees, many of them on the front lines. Really quite extraordinary. And then, of course, what Dr. Browning was telling us, so key in managing the front end of all of these potential problems. We focus more on the back end. And by that, I mean, in the case of chronic pain actually drives 80% of the overall costs in comp. Because if you think about it, if a patient has no pain or pain-associated symptoms, you really don't have much of a claim there. The remainder of the claims don't involve chronic pain. Now, historically, the problem has been that for many decades, chronic pain has been the largest epidemic in the United States, which means it's also been the largest epidemic in the work comp space. But it was only until 2005 that we identified in the literature and in the guidelines that work comp is that chronic pain is a major epidemic. So in the year 2000, there were over 70 million people in the United States suffering from chronic pain, and that didn't include soldiers coming back from Iraq, it didn't include children, and it didn't include seniors. So we're looking at over 70 million people suffering from chronic pain. And Congress conducted one of the first studies in terms of a report card to see how we're doing with respect to chronic pain. And what the study came out with was that of the 133 medical schools in the United States, only 3 had an elective topic on the treatment of chronic pain. And if you're familiar with medical curriculums, they are so robust. There's so much material that trying to stuff in additional material like chronic pain is extremely difficult. So when we're looking at 70 million people with chronic pain in 2000, who is treating all these patients with chronic pain? And that's part of the problem. So Congress mandated a lot of changes in the way we have to think about chronic pain, moving from a biomechanical or a biomedical model to a much more evidence-based model, which is referred to as a biopsychosocial model. And working with insurance carriers and employers and research organizations, a lot of work was done to improve outcomes. 10 years later, in 2011, Congress mandated the National Institutes of Health, which commissioned the Institute of Medicine, to do a new study. And what they found in 2011 is we went from 70 million people suffering from chronic pain to over 125 million suffering from chronic pain. And in terms of medical educations, we went from 3 medical schools having elective topics on the treatment of chronic pain, 10 years later to 5 schools out of the 133 offering any training with respect to chronic pain. So it's been a major problem. And when we look at that, we're speaking about chronic pain annually costs about $635 billion. It's the largest health epidemic in the United States. And I'm going to touch on the impact of COVID in a minute on chronic pain. But the good news is, and I think Ken, you mentioned it in terms of evidence-based medicine and MTUS guidelines, the good news is that if you drill down and you look at chronic pain syndromes, which are the largest cost driver and contribute to a great deal of disability, you can systematically reverse chronic pain syndromes. And the way to do that doesn't necessitate changing our society, but actually in a microcosm. As an employer, you could insist that your treaters actually employ the guidelines. And the guidelines I'm speaking about in California are called MTUS guidelines, but nationally, they're either the evidence-based guidelines of the American College of Occupational and Environmental Medicine or the official disability guidelines. And by the way, you don't have to take notes down because in our references, we have that material. The point is that despite the fact that chronic pain is the largest cost driver, it can be systematically reversed. And specifically, when a injured worker goes through a chronic pain rehabilitation program, in most cases, they will hit MMI and PNS. And that's whether they've been suffering from a year, 5 years, or 10 years with their disability. They will reach MMI within that window of treatment. Then there's another area, and that is brain injuries, something that many people are very fearful of. And one of the reasons there's so much fear about brain injuries is because if we look at the research coming out of the Brain Injury Association of America, we see that very few people are actually trained in how to diagnose brain injuries and how to treat them. Because if they are diagnosed appropriately, treatment is robust as it should be, then the outcomes are terrific. Part of the problem in the work comp space is that we don't diagnose effectively, so we do not engage in targeted treatment with respect to brain injuries. And I'll give you an example. Very often, when there is a suspected brain injury or blow to the face or the neck, a neurologist might be the referral, and then very often a neuropsych eval is requested. But the reality is that If we just stick to a neurological eval and a neuropsych evaluation, most mild to moderate head injuries will not be uncovered. So what happens is you have these issues that are preventing an individual from getting better, but their symptoms are not readily manifest. So treatment cannot be targeted towards the underlying mechanisms that are contributing to their problems. Hence, you have delayed recovery. Now, in the case of chronic pain, you have delayed recovery if the treatment isn't appropriate, and in most cases, it's not appropriate. In the case of brain injuries or head injuries, if the pathology or the underlying mechanisms aren't identified, then you just have patients who aren't getting better. So if they're being treated for chronic pain and you see they're not getting better, you have this delayed recovery, which doesn't seem to progress. Hence the importance of doing what we call a comprehensive biopsychosocial head evaluation or concussion evaluation. Because with such a comprehensive evaluation, what you are looking at, using EEG as well, by the way, and computerized balance testing and so on, is you're looking at those areas that have been impacted. And for those of you who are particularly familiar with the concepts of neuroplasticity, the ability to compensate for brain injuries and to heal is quite extraordinary in a very limited period of time. So the 2 points I would bring up is one, chronic pain, despite the fact that it is the #1 cost driver, can systematically be reversed in terms of disability. Brain injury is the same thing. And then the final point is PTSD. And PTSD is another area that many people are very anxious about. We run a military grade PTSD program. I think if I leave one point for you to consider, and that is, while PTSD can be routinely healed, complex PTSD can also be routinely healed to the point that most people with complex PTSD can be systematically healed within a very short order of time. And for those of you who are interested in this information, again, at the website we have at the bottom, institutesofhealth.org, you can find out a lot about that information. But the bottom line is, as an employer, as long as you're making sure that those injured workers are receiving the right kind of evaluations and the right kind of treatment, you can rest assured that they will reach MMI and be PNS'd. How do you do that? Well, there's no surprises here. The evidence base we have for being able to systematically reverse chronic pain, PTSD, and head injuries is in these compendiums of the American College of Occupational Environmental Medicine, as well as the official disability guidelines. There is over 50 years of outcomes research that demonstrates that if you use if you employ an evidence-based biopsychosocial approach to treating these conditions, systematically, you will reverse these conditions. Now, what's been quite extraordinary is over the past 15 years, our leadership has been working on building a platform, which we call a biometric telehealth platform, which permits us to be able to deliver treatment to people in remote areas. And it was only as a consequence of the demands of COVID that forced the demand for us to begin delivering treatment to anybody, anywhere. And the reason we refer to it as biometric telehealth, what we do, is that it's not just a video conference. What we do is we actually have devices on the patients that give us objective data, because as you know, in comp, one of the problems is we rely a lot on the subjective data that we get from patients. But when you have biometric devices on patients, we're able to see what they're doing, how they're walking, what they're doing in the water. Even if they're going into a pool, we can get a stream of information in terms of what they're doing. We can tell what they're eating. We can tell how they're sleeping. With all of this data, even, by the way, we're able to get EEG feeds from them. So we're able to see exactly what's going on with the patient, and we're able to target with that ongoing feedback. We're able to target treatment and move patients along the way to healing. This is also extremely important because it also permits us to keep patients at work. And staying at work is one of the most important healing factors we have, as is return to work. And so what the biometric telehealth permits us to do is transition patients as quickly as possible back to work, and also to treat them in their workspace. So what we're doing is we're treating them in more of a real world environment. You know, historically, we've been very good at simulating reality in hospitals and clinics with our equipment and so on. But the reality is the best way to treat an individual who's suffering from disabilities as well is to treat them in the real world. And that's what biometric telehealth permits us to do. Let me just give you a couple examples, and that'll be it for me
Dr.
right now.
Dr. Anbar, we're running a little bit
That's fine.
short on time, so you've given us a lot of great things to consider, and I'd love for Ken and Dr. Browning to turn on their webcams again so we can see their lovely faces. Ken, I had a follow-up question for you, because one of the things Dr. Anbar mentioned was the biopsychosocial treatment model. And one of the comorbidities from a biopsychosocial standpoint is fear avoidance. And you really talked about fear in relation to your team. And it blew me away when we were having our prep meeting that that patrons would actually spit on your employees. That just blows my mind. And certainly it's not necessarily, you know, just restricted to that. So what are some tips for employers that may not necessarily have the same kind of environment that you have, but still have a fear of avoidance of returning to work, and the fear of a safe workplace? What are some tips that you could give some employers that are on the call here to consider in their risk management outreach?
Well, thanks, Mark. Thanks for that important question. And I think I have both environments. We have the frontline employees that obviously get spat on, and that's a major issue, fear there. But I think we also have our support staff and administrative staff that are, a lot of them are telecommuting, and they're afraid to come into the workspace for fear of COVID. So along those lines, some of the things that it's important, in my opinion, to do is understand what fear is, understand the culture of fear. And when you have the convergence of social media and the uncertainty, it creates problems, and it creates the animosity and the fear of coming back to work. I think that we need to be cognizant of the fact that that is their perception, first of all, and that we have to be sensitive to that perception, and we need to address what their concerns are. I think it's important. What some of the things that we've done is we've taken surveys of our employees that are out about return to work and what some of their fears are, in order to highlight some of those areas and what we can do to try and mitigate some of those concerns. So we've done surveys, we've got committees, so we have them involved in the return to work process. What would they be comfortable with seeing when they came back to work? What's some of the environment that they're looking for as we go towards what we call the new normal, not knowing what that's going to be? And so we've tried to address their concerns by getting them to express that and trying to mitigate some of those concerns and have their involvement help them come back to work. And I think that's important to get their input and to get their buy-in.
Yeah, absolutely. And Dr. Anbar, you talked about staying at work and being as important as return to work. So Ken's given us some insight into the engagement that you want with the employees, and kind of understand their perceptions. And as we all know, perception is reality. What are some tips that you would give to employers from a stay at work standpoint that have gone back there that we don't want them to leave again?
I think education is the cornerstone of mitigating risk and dealing with people's fears. So on the one hand, giving appropriate education. And by the way, Mark, you've made reference to not spending so much time in social media. Social media is devastating people. And I think it's important for us to be able to educate users of social media in terms of how those stressors are affecting their hormone levels, biochemical levels, how those stressors are exacerbating many of the symptoms they have, even whether they're diabetics or hypoglycemics, and to explain those mechanisms. Give them a sense of control over their lives at a time where people don't feel in control.
Yeah, and that's precisely why I've grown my beard. That's about the only thing I control right now. I was able to give good news to my wife that I am going to shave it on January 1st. The problem is that I'm going to look like Cousin It by the time of that. So it was kind of bittersweet news, but there are a lot of things completely out of our control at this juncture. And I think education at least gives them that ability to do that. Dr. Browning, I wanted to ask a question. We've discussed a lot of trends and statistics specifically for health and what you're doing. What do you see as some emerging trends? Because we talked about it kind of at the end of your section, that work comp is embarking upon a journey we got no clue out. We historically have not dealt with diseases on a mass scale in regards to compensability. We're talking about fatigue and pulmonary issues that historically have not been related to work comp that might be long term. So in your estimation, getting either your magic 8 ball or your clairvoyance ball, what would you see as the main things that are going to evolve as we go into 2021?
Well, let's talk about the easy ones that people have already hit on, that Dr. Ambar hit on, which is educating people away from fear. First, people should understand that the PPE is effective, and that people like our firefighters in Arizona that I talked about only have a 1% risk. So I think the education is going to be important. We really need to get a handle on understanding why these prolonged symptoms occur. There are lots of ideas about it. It has to do with the immune system and hyper response to things and damaging the lining of blood vessels and things like that. But I think scientists are going to be very interested in understanding better why these long-term things occur, and are there ways that we can manipulate the immune system to help to mitigate some of those problems. And then I think understanding the psychological issues. And in fact, if I may, I had a quick question for Dr. Ambar on that. I was fascinated by your comment about systematically reversing PTSD. I wonder how PTSD in the COVID setting might look different from the other causes of PTSD that you're used to seeing.
I think that's a great question, and that is the importance of being able to do a differential diagnosis between PTSD and complex PTSD, and also acute stress. And I think the good news is that typically on the OCMED level, we're able to effectively treat PTSD within 7 sessions. Complex PTSD is a different story. The fears that are generated by COVID complicate the issue. There's very often a lot of latent issues that these stressors will push to a level that appear to be PTSD. And then, of course, those cases that do become PTSD have to be addressed as quickly as possible. But Dr. Brown, you mentioned something interesting that also touched on something you said, Mark. And that is, when we look at the overwhelming stressful impact of social media and everything we're hearing about and all the uncertainty regarding COVID, that ongoing stress, which you can control the volume of by just shutting off the news and reducing the amount you're watching on social media, that ongoing stressor impacts immune function. And so the greater we have this chronic stress going on that we can control, the greater is our vulnerability to viruses, bacteria, and cancer cells, which takes us into this whole biopsychosocial realm. And so again, the amount of control we have over our lives to protect ourselves is much more significant than we often think about. So remaining healthy, eating well, or eating healthy, I should say, exercising, and reducing stress are key factors that will help protect us and help us heal faster in most instances.
I think that's great advice, and something we've certainly heard over and over again, trying to do self-care. And self-care has physical and psychological negative or positive impacts. I know we're running over a little bit. Hopefully Diane will put another quarter in the meter, because we've got one question that came in from the audience, and I wanted to toss it out to you guys. What kind of permanent damage is being seen due to COVID? In other words, I've known of someone who had COVID and they successfully recovered, but 2 months later, their sense of smell and taste still has not returned. Any of y'all want to take that on?
I'll jump in first. Yeah, the sense of taste and smell. There are some people where it doesn't seem to be coming back. Most people, it does come back. The bigger question, not that the taste and smell isn't a big one, but is this fatigue, this inability to get up and do the things you need to do to go to work and do all of that. And we just don't know how long that's going to last. And, you know, there are lots of stories where somebody gets better from their illness and they think it's all done. And then suddenly this fatigue and chest pain and shortness of breath and everything comes back. So I don't think we have a good answer just because we don't have enough time yet.
And I think what complicates it even further is the psychosocial impact this has, and all the people who are feeling so depressed. And then, of course, the worst part of all is the increase in suicides we're seeing, because this is just pushing so many people over the edge. And as we saw in a recent study, 25% of young people, teenagers, have active suicide thoughts.
Yeah, there's been a term called deaths of despair that has really picked up traction in the media in regards to overdoses from drug abuse, suicides, and that kind of thing. Well, we are definitely out of time. I really appreciate Ken, Dr. Browning, Dr. Ambar, your input on this. I think it's been highly valuable. Hopefully everybody in the audience got some stuff from it. As we mentioned, there's a handout, as Diane mentioned, and you'll see the additional resources page. So for some additional reading, if you're interested in there, we gave you some links to that. With that, Diane, really appreciate the opportunity to be a part of your webinar, and we will turn it back over to you.
On behalf of Workers' Comp and Motion, we'd like to thank our experts for joining us today and sharing the information. We do have another webinar that is going to be this week on Thursday, so please join us for the nuts and bolts of SB 1159. In a nutshell, we have 3 speakers that are going to be speaking, and there'll be a vast amount of information that they will be sharing with you. So the other thing we'd like to remind you about is that your certificate will be coming in 24 hours, so make sure you watch your email so that you can get that. And now, the winners of our prizes. So we have our sponsors, and you can see them all listed here on the left, and we have our winners' names. So please look at this, see whether or not you are a winner. If you are, please be sure to reach out to your contact there at the company. They will also be reaching out to you to get those prizes to you. I'm going to leave this up for just a moment so you can see who the winners are. And again, we'd like to thank you very much for joining us today, and we'll see you on Thursday. Bye-bye now.